or quality-related problems. And by recognizing those outcomes, generally we can shift our safety and health programs and our production-related programs to maximize the utilization of our employees and what they provide for us in terms of productivity. It also helps to retain good workers. And again, turnover, absenteeism, and quality-related problems are all factors to concentrate on.
Thanks.
An interesting new development involving my program is that we actually have a psychiatrist who is dealing with the impact of stress in the workforce related to work-related injuries. And they're actually implementing programs throughout many industries now where they will work very closely with individuals who have been injured to deal with the stress component. They do this both pre-injury and post-injury, and they have found that this significantly reduces, once again, the disability time associated with this. They have done studies to show the cost efficiency of this, and it's a relatively new thing, but we're very excited about the potential for further lowering disability costs.
We have another live phone call now from Cimentos of Pasco in the state of Tabasco. Go ahead, please.
Good morning. We have a question. Amongst the factors that have something to do with productivity, how much will the attention to health and personnel health and safety have much to do with the productivity?
Exactly. What is that correlation in your view?
Well, I think part of what will come from Dr. Fuller's discussion, and he has already indicated that a healthy workforce is a productive workforce, and there are many studies that bear this out. One factor to concentrate on is that a healthy workforce stays at work. They stay at work and they capitalize on the training and education that has been provided to them. And by doing so, they enhance productivity. Part of what is essential as we look at today's topic is that change, the dynamics of work and how work is organized is changing. And maintaining the health of a workforce is essential, and the factors that impact their health will be changing, and both of which are essential to maintaining productivity.
And Dr. Fuller will be speaking about that in the next module. Right now we have a call from Bolivia. We welcome Bolivia and Universidad Privada Boliviana. Go ahead, please.
We have a question for you. If I decide within an organization to implement strategies to improve physical health and also to improve mental health of my workers, do I have to pay more attention to the mental health or to the physical health of the worker? What would you think? What would you say?
My experience has taught me that you cannot ignore one over the other. It is a difficult answer to your question. Certainly the development in the United States, as I will go into in part of my presentation, started with physical and did significant improvement in overall cost associated with those injuries by dealing with the physical part. But as we have continued to mature, we have found that the psychological component associated with these injuries, both without any specific injury, associated with a specific injury, or standing alone, end up being a significantly costly effect. And it is a developmental process which I would encourage you to look at both components as early as you can do so.
Very well. We next have a call from Universidad Tecnológica de Panamá. Go ahead, please. Go ahead, please.
The question is the following. How can you say holistically, how can you include or implement certain considerations related to biosecurity in the workforce and performance to attain higher productivity, where you have population that is very sick, and it is from there that we hire people for the organizations. And so when their performance is precisely hindered because of their lack of fitness to work because of the physical
Yes.
problems.
Yes, we understand. Thank you. Dr. Fuller?
Certainly, this is a concern in all countries. In the United States, there was something recently passed called the Americans with Disabilities Act, which was an attempt by the United States to put approximately 40 million people back into the workforce. And this is dealing with a part of your question. But I think it is a matter of degree. By that I mean that regardless of the workforce that you start with, if you associate or try to develop both strategies to reduce any further disability that they may come in with, or to improve their level of performance by preventive programs and educational programs, you will only be better off than you are now. So any attempts that you make to either improve their health or to reduce the resulting injuries and illnesses and therefore disability of these people, your total productivity will be better.
I would also like to add that part of what I was trying to express earlier had to do with the educational aspect of assisting your workforce. By educating them as they enter your organization, they become better students of health, so to speak, and will come to work in perhaps a more fit state, in a better capacity to work, and will be more productive for you. Also, organizations might want to consider assisting their workforces and employees in access to care, and by doing so, they will receive much of the benefit by way of productivity and retention of very good workers.
Fine. Next we have a phone call from Universidad Iberoamericana in Torreón. Go ahead, please.
William, Mexico. Buenos días. Do you think that the programs, the health programs, should begin by salaries that, and do you think that they should have some general conditions that are acceptable to workers? Do you think we should have a healthy environment for people who just enter the organization?
Could you amplify that question a
¿Podría
little bit?
usted do you think that the health programs in the job should start with fair paid jobs, and should they also have general working conditions that are acceptable?
Okay.
I think we both could comment
Yo
on
creo
that.
que ambos.
Certainly, the impact of a healthy workplace on the worker is crucial as an underlying situation. Now, once again, I will talk about this, and we deal with industry all the time, not just in dealing with the human being, but also with dealing with the workplace itself. Both having people who earn enough money to have a healthy lifestyle is important, but certainly dealing with the workplace itself and making it less hazardous is crucial in terms of occupational medicine, and once again, directly related to your bottom line.
I couldn't agree more, and if you look at the systems approach to what we talked about a little bit in my earlier presentation, you'll recognize the fact that not only do you have to include enhancing the health of an individual, but the environment in which they work in, and that environment clearly includes the workplace as well as the off-the-job environments, the kind of the social structure that they come from and that they participate in, all of which are important factors.
We now have another phone call from Comisión Federal de Electricidad, Auditorio Atoyac. Go ahead, please.
Buenos días. Respecto a los controles en base a capacitación.
As far as the controls based on training to avoid accidents, what are the strategies that you think we should be implementing for better results?
I think that's a great question, too. And part of what we try to concentrate on for example, in a U.S. model program, is that training should clearly be related to what you have historically experienced. In other words, I have a saying that I use with many of my clients, and that is, you cannot train away the woes of the world. However, it is a critical factor to success in managing the health of a workforce. You should look at the historical trends in your injuries and illnesses and make sure your training program is related to those, and also look at what is coming up. For example, with change, with the dynamic changes that we're seeing in globalization, changing economic structures, and the ability and how we accomplish tasks. This is where I use the word preemptive, and by preemptively looking at some of these factors, you will be able to shift your training programs to gear up for this and take care of risk factors before they actually hit.
Dr. Fuller?
I want to amplify specifically one point that Mr. Hopwood made, and that is that we deal with lots of industries who perceive their problem to be one thing when in fact it is another, and we now have computers that help us monitor the frequency of specific injuries in industries, and how many injuries and how many certain types, low back strains, stress-related disorders, whatever. But in most industries, somebody in the human resources department can simply keep a log and tally this. And it is very important to, as Mr. Hopwood said, select the area that you're having your problem with and designing the program to meet that. There are lots of relatively preset lectures or presentations on how to avoid certain problems, but you have to identify what the problem is first and do it very concretely.
Very well. We have a call now from Costa Rica, from Universidad Estatal a Distancia in San Jose. Good morning.
Buenos días, Sam. Saludos a todos, encantados de estar participando.
Thank you very much for allowing us to participate with you this morning. We have a question for you. Page 27, you're talking about 87% of lack of safety. I don't know what do you think this is due to? Lack of organization, lack of information, or lack of training for the worker, or because there are no policies that prevent all these accidents from happening? Or do you think is it because we lack a methodology and a lack of control or monitoring of risks? Do you think that's the thing?
I believe that all of those factors you just mentioned are included in that 87% of injuries and illnesses are thought to be the result of unsafe acts. More specifically, what we have experienced in the United States is that 87% of injuries and illnesses emanate from unsafe acts, primarily because of the shifting way in which we accomplish tasks and the way we make things. As we move farther and farther into an information world, a technological world, and the service world that we talked about, it is clear that the factors that impact the health and safety of workers on the job are those which they have some control over. In other words, lifting properly, utilizing the proper posture and activities at a workstation, a computer terminal, for example, all of which they have some control over. And it's this point, the unsafe act, as opposed to a condition which exists, such as something on the floor that we might trip over, or an unguarded machine, that has been taking more and more of the percentage of total injuries and illnesses.
We welcome now a call from Argentina, from Universidad Nacional de Córdoba. Good morning. Do we have the call?
Hola, hola.
Good morning.
Sí, un segundito. No está saliendo al aire, Raúl. Hola, sí. ¿Pueden repetir la pregunta? A ver, no, todavía no sale al aire. Raúl, si lo puedo dar al aire. Hola.
Who's asking the question is not coming through.
Very well.
He doesn't want to relay the question. Hello? Adelante.
Okay. We apologize that call was not coming through properly and we couldn't receive the message. We do have another fax in from Universidad Privada Boliviana again. If education is positively correlated with production and health, what are some strategies employees can adopt to assist in educating their workforces?
Employers can clearly take advantage of some strategies which include bringing education to the workplace. By enhancing education that takes place on the job, much benefit is gained, not only technical benefits to the job themselves, but enhancing the ability of workers to make an impact on the job, in their social environment, as well as with their families, all of whom in many cultures and in many communities end up being the future workforce for a particular organization.
Thank you. Next we have a call from our neighbors in Tijuana from Instituto Politécnico Nacional CITEDI. Good morning, and go ahead, please.
One of the questions that we have is that one of the manifestations of stress is through your mouth. How do you think we should approach this in the industry, or how can you regulate health programs?
The question has to do with stress, but we weren't quite sure.
El estrés es el What do you think the importance of dental services, the importance of dental services in the industries? Do you think that's an important factor to be considered?
Very well, we understand now. Thank you.
Dental care varies significantly from area to area, and certainly country to country. Any health-related problem which produces a disability, in my opinion, should be addressed. And if dental health is a significant concern, the same way I was talking about identifying what problems there were in the work site itself, you need to also identify what are your health-related problems which are producing a disability within your workers. And if dental health is a major problem, finding some way to help that situation, once again, will only produce a benefit. Many U.S. employers have dental insurance as part of the plan. It becomes a cost-benefit analysis at that point to figure out whether the benefit produces the cost-effectiveness that industry is looking for.
We now go to La Paz in Baja California Sur. Medicel, go ahead, please.
Baja California Sur. Muy bien. Since here we have small enterprises, we would be interested in receiving some kind of strategy to increase productivity for small businesses, because we are so young. So the risks and the medical costs are very high. And particularly because it's a small population, and because we have very few employees, and therefore, and we have to pay high premiums for insurances. Could you give us some ideas about a strategy to solve that problem for small businesses?
We understand. Thank you.
Any of these strategies that you might adopt will cost something, and once again it becomes a cost-benefit analysis, which I will go into a little bit more in my presentation. However, I will say that the series of steps that an occupationally trained physician can help with include selection of the correct worker. In other words, you really need to place people in a way that they won't get hurt. Number two, any preventive programs, if they are well put together, and once again, it'll depend upon the type of problems that you are having there. But prevention is almost universally cheaper than treatment and the disability associated with it. So I would strongly encourage you to look at some form of selection process of your employees and entering some form of prevention focused at your major problems. And oftentimes it can be a very confined look. If you are looking at a specific area where your number one problem is cutting fingers from certain types of work, you need to put on guards. Very simple modifications can sometimes save large numbers of dollars, both in medical costs and disability costs, therefore reducing premiums that you might otherwise have to pay.
But I would like to expand on one point, and that has to do strategically. If you do one thing well, whether you're a small, emerging, or long-standing organization, and that is to recognize the factors which are injuring your employees. And by doing so, that strategy doesn't change. Whether you do it now or you do it in 5 years or 10 years, or if you're a small or a large organization. And by recognizing the factors that impact the health of your workers, you will be well on your way to implementing the strategies that Dr. Fuller has just mentioned and will mention in his presentation.
Thank you. We have one more call coming in now from Comisión Federal de Electricidad, División Golfo Norte. Go ahead, please.
Buenos días.
Good morning.
Good morning. Our question is, what are the indicators that you use to evaluate the importance of organizational stress, or how the implications and how it actually impacts, and what kind of other statistics do you have on a geographical level?
And how do you know when an organization has too much stress within?
There are several ways, and let me talk first about a couple of the U.S. models, if I may. One certainly is the manifestation of stress-related claims on any insurance form, whether that be a workers' compensation, injuries or illnesses that derive from the workplace, or those which happen in your own medical insurance. We certainly have seen, as the factors of work have changed, as the organization of work has changed, that the mental stress outcomes have grown. There have been some legislative dynamics in the state of California, for example, in the last 2 or 3 years that have mitigated these a little bit. But clearly that's one way to find out, is by looking at the insurance activities.
Once again, my experience has taught me that industries in the United States quickly learned years ago that the use of employee assistance programs purchased through outside vendors, whatever, to be dealt with on a case-by-case basis has given them some statistics on the cost of disability related to stress, because they've been able to then capture those situations and capture the numbers of people being affected by that. And therefore you would have some monitoring and some experience here. It varies widely from industry to industry, but there is virtually no major U.S. industry that does not have some form of employee assistance program for non-occupational, non-work-related injuries and illnesses. The interesting development I mentioned earlier is that there is now a field of occupational psychiatry and psychology which is believing that those same types of efforts should be focused on people who have problems associated directly with work and the injuries and illnesses there. I do happen to know that the U.S. Post Office is looking at these types of things, one of the largest employers in the United States, and they are looking at ways to reduce this because of enormous disability and other liability costs associated with stress on the job.
Thanks very much, gentlemen. Let's continue now with Module 2, in which Dr. Fuller will explain about how businesses and healthcare organizations are working together to improve the productivity of our workforces.
Thank you. Many physicians and business leaders believe that business and healthcare are by their very nature adversarial. I happen to believe, as do many occupational medicine physicians, that good medicine equals good business. I hope to offer a few reasons for that belief today. Occupational medicine is a subset of preventive medicine. It is now one of 2 underserved medical specialties in the United States, with family practice being the other. This shortage is partially due to the fact that occupational medicine is a specialty that has had recent resurgence, but is also occurring because industries believe that the financial outcomes that they achieve are better with occupational medicine physicians. In my presentation today, I would like to give you information regarding the relationship between the health of workers health of workplaces, productivity, and the blending of occupational and non-occupational health. I would like to give credit for some of this material to a document published by the California Senate Committee on Industrial Relations entitled Healthy Workers, Healthy Workplace, the Productivity Connection. I would like to break my presentation into 4 components. First, the history of workers' health in the United States. Second, the currently existing occupational medicine program model. Third, the impacts of workers' health on business. And finally, future developments. As a background, I believe that health problems at work may involve illness or injuries or psychological problems at both. Manifestations in the workplace of poor health can include absenteeism, sick leave, high employee turnover rates, premature disability and death, impaired quality of product or service, high rates of accidents and errors, poor performance and job dissatisfaction, and bad communications and group conflict. These issues all impair efficiency and result in poor rates of labor productivity. They obviously change depending upon a multitude of factors, economic, cultural, and legislative, among others. The question presented to me daily by industry is whether I, as an occupational medicine physician, can do anything about these issues and the resultant costs. History of efforts to improve the health of the U.S. workforce began with passage of workers' compensation laws in the early 1900s. Prior to this time, many workers had no health insurance to cover issues related to work or unrelated to work. This workers' compensation insurance produced a no-fault form of insurance to cover the cost of medical care and disability associated with work-related injuries. It was originally limited in scope. Many workers were still left without any health care coverage, particularly for any injury or illness not the result of a single episode at work. For example, an employee who cut his finger could get medical care and disability payments, but an employee who had lung disease from years of coal dust exposure could not, because it was considered a cumulative injury. This coverage has extended today to include almost any form of injury. During World War II, many large industries began to provide general health services directly to employees and their dependents. This aspect of employment became a common fringe benefit and important to recruitment when labor supply was scarce. Unions became very powerful in obtaining a more complete package of insurance for non-occupational medical care. In the late 60s and early 70s, occupational health and safety regulations became more prevalent with the passage of the Federal Occupational Safety and Health Act. This act began a series of occupational health and safety regulations to protect workers and to hopefully reduce the cost to employers and workers resulting from these accidents and injuries. For example, hearing protection standards were passed obligating employers to monitor noise levels and hearing in employees if the noise level was too high. Next, pre-employment and pre-placement examinations have become an established procedure for many U.S. industries. Originally, they were designed to keep people with pre-existing conditions and handicaps out of employment and thus to avoid any increased financial burden due to medical or disability costs to the employer. Today, due to a series of laws in the United States, particularly the Americans with Disabilities Act, this purpose of pre-employment examinations has been eliminated and has been replaced by the desire to place these people safely in the workplace with what are called post-offer pre-placement examinations. The goal of these examinations now is to avoid the disability cost and reduce productivity from placing people in a job that would injure them. Recently, mass health screenings and preventive services, for example, health education and vaccination programs, have been instituted by industries to identify and prevent common health disorders not necessarily connected to work. The costs associated with all of these health and disability issues have become significantly more burdensome to U.S. employers. They are currently attempting to reduce these costs through a variety of financing mechanisms such as PPOs or preferred provider organizations, HMOs, or point of service plans, disability management programs, and the merging of group health and occupational health programs. All of these are basically efforts by industry to increase their bottom line by reducing costs. As an occupational medicine physician, I believe that the goal of reduction of health and disability costs and increased productivity by cost-effective, quality health care is both possible and appropriate. Our current occupational medicine program is based on the following model. It is based on the belief that what is best for the patient is also best for the employer, and that good medicine does equal good business. The concept is that the patient/employee should be the focus of three parties: the employer, the medical provider, and the insurer. These three parties all have primary jobs directed toward the patient or employee, and all need to communicate with each other to make the model work. The employer needs to provide a safe place to work and communicate effectively to the provider and the insurer. The insurer needs to cover the expenses generated by the injuries or illnesses and communicate to the provider and the employer. And finally, the medical provider needs to provide quality medical care and preventive services and communicate effectively with the employer and the insurer. For example, as a medical director for Sharp Healthcare, I only hire physicians who both can practice good medicine and effectively communicate with the other parties in this model. Most physicians do not believe that this communication is part of being a good physician. Occupational medicine physicians know that without this communication, the patient will not recover from their illness and injury as quickly as they would otherwise, and that the cost of the model will go up. I firmly believe that this model has allowed my company, Sharp Healthcare, to produce one of the most cost-effective products for industry in the United States. Currently, our occupational medicine program provides the following services: pre-placement examinations, workers' compensation injury and illness care from primary care through hospital care, drug and alcohol testing, OSHA-mandated surveillance programs for such things as lead and asbestos, fitness for duty examinations, preventive medicine programs such as vaccination programs, education programs, toxicology or ergonomics evaluations, rehabilitation programs, executive health, and finally consulting on any of the above services to industries. This occupational medicine department is then surrounded by non-occupational primary care and specialist physicians in all other fields of medicine, so that San Diego industry can use our institution for both occupational and non-occupational medical care. More experienced industries use more of these services than inexperienced industries. I believe the reasons they use more services are: first, preventing illness and disability is cheaper than treating it. Second, early intervention is cheaper than later intervention. And third, many disabling conditions such as drugs and alcohol, stress, and chronic diseases have their origins away from work. The result is that the occupational health field continues to expand to cope with non-work-related issues, for example, problems of lifestyle and chronic illness.